Hello, everybody. Thank you so much for joining us today for our webinar session. We are having people joining us as we're currently speaking, so we'll just give it a few more seconds. For everybody that has joined us so far, this session is being recorded. So unless you want to speak and you're happy to put your mics on and your cameras on, then please do. But otherwise, we're happy for you to keep them off. I appreciate it's around lunchtime too. So whatever you need to do. We have got a Q&A session here. So if you do have any questions, please drop them in the box and we'll keep an eye on them. Anything that we can't get through today, we will reach out and make sure that all the questions are answered. So that's absolutely fine. It's pinging low, so there's still loads of people joining us, which is brilliant. I'm going to give it a few more seconds whilst everybody joins us. So if you haven't already grabbed a cuppa, then you've probably got 30 seconds to do so. It's lovely to see so many people here. It's absolutely amazing. We do have a lot to cover in the next 60 minutes. So I wanted to say, bear with us. This isn't meant to be, you're not meant to sort of remember everything that we're going to go through. We're going to be telling a lot of stories. So again, if you've got any questions about anything that we're talking about today, then please reach out. This is meant to be an interactive session, so we can keep in contact with you over sort of today and the next 4 weeks too. Conscious of time, we've still got people coming in, which is amazing, but we will crack on if everybody's happy to do so. So first of all, welcome. We are hosting our webinar. This is webinar 1, so finding new ways to improve healthcare for everyone in West Yorkshire. It is part of the Learn, Connect, Empower webinar series, and today we are understanding the essentials. So I'm just going to move this on. Okay, so whilst we're waiting for him to join, it's probably a good time to start. We do have a very, very basic pre-session sort of survey. If you can scan the QR code, Molly is just about to put the link into the chat. So this consists of 3 very basic questions, and essentially it's just to gauge your baseline knowledge. It will hopefully take you about 30 seconds to complete. So thank you so much, Mal, for popping that in. So if everybody wouldn't mind, if you could just look at that link and answer the questions. And like I said, this is just to gauge your baseline knowledge on some of the topics that we're going to be covering over the session. We still have people coming in. Just going to give you a couple of seconds for everybody to get the QR code. Okay. The link is in the chat box, so I'm going to move on. But if you don't have chance to get it, just give one of us a prod, and we can. We've got some things in there about permissions. Is that right?
Yeah, Kim, can I just come in on that one?
Yeah,
Just to let you know, we've got a few people in the chat unable to grant permissions to go onto the farm. We have had some responses. So if you bear with me, I'm going to fiddle around with the settings, and I will pop in the chat once I've done so. So if you're still unable to answer, we can send it out via email as well after. So if you bear with me, I will let you know in the chat. Hopefully, fingers crossed, I can fix it.
Real, thanks so much, Mal. Okay, so we'll move on then. So there we go. So just to start then, this is a little bit about me before we start. So this is me and my 2 little humans. This is my daughter and my son, Tilly and Edward. So my name is Kim Frost. I live in a beautiful area of South Yorkshire, and I've got 2 beautiful kids, as we just established, who are incredibly lucky enough to go to a great school. And that's permanent because my daughter suffers with her mental health. Her school is absolutely wonderful, and they picked up on that incredibly quickly and got her the support she needs. So what else about me then? So I have a degree. I have an incredibly great job, which provides me with autonomy, development and stability. Most of my career has been spent in the NHS. This is an advantage because when I myself have been a patient or my family members have been a patient, the information that I've been able to sort of hone over the past, 7, 8 years has been a massive advantage in that scenario, which has also meant I've had, great access to healthcare. I've got a really wonderful support network. So they have seen me through the life's ups and downs. Why am I telling you this? So I'm not telling you to brag. I'm highlighting how incredibly lucky I am. I am a white female, and that has given me autonomy to influence my own life and the work that I do and how that has impacted me. However, I truly understand how different that could have been. So this is another picture of me taken many moons ago. This is me and my beautiful mum on the Millennium New Year's Eve. Very retro. So I was 9, nearly 10, going on, 30, obviously. So my mum grew up in absolute poverty with little to no education at all. However, she was incredibly smart and incredibly driven, but her family didn't prioritise education and she was taken out of school very, very young with no qualifications. She met my dad, who was also from an absolute poverty, both grew up in deprivation, and he also had absolutely no education to his name at all. They had 4 children. So they had 3 children before she was 20, 4 children in a very early 20s. So you can imagine how insanely chaotic that would have been. And we also grew up in absolute poverty, but I was incredibly loved. Despite attending a school, which was in special measures my entire education, my mum did instill in me great work ethic, and she really stressed the importance of education. Very sadly, my mum was diagnosed with stage 4 cancer in her 40s, and which was an incredibly difficult time for our family. It meant I delayed going to university, so I could help care for her. She became really, really ill and passed away not long after that. I couldn't afford university at the time. I knew I needed to work. So knowing that I wanted to work in healthcare, I started my wonderful career in the NHS as a Band 2 administrative support. I was really determined to improve my situation, so I started studying full time for my degree through the Open University. I worked full time whilst doing this because I couldn't afford to not work, and I was raising my 2 young children. So throughout the 3 years of study, I developed professionally and progressed in my roles. So I became Deputy Governance Lead in an acute trust, which I was incredibly proud of. And today I'm a fellow on the Improving Population Health Fellowship, and I work at Health Innovation Yorkshire and Humber. And I get to do things like this. So I'm incredibly lucky. And thank you all so much for coming today because it means a great deal. So why am I telling you this? Well, bottom line, I've absolutely got no doubt in my mind that my mum's death was the result of deprivation of the health inequalities that she suffered. So due to fear, a lack of knowledge about the illness, about embarrassment, stigma, the fear of being judged, lack of knowledge, education, and she had exceptionally limited means to improve her situation. She didn't seek the medical help that she needed. So this is my story, but this is, one of absolutely millions out there in our country. And someone explained it to me sort of during COVID. We're all weathering the same storm, and I believe the same can be said about our health. We all have to look after our health, and we're all weathering that storm. But when it comes to looking after our health, we're all in different sized boats. Some of us are in absolutely massive cruise ships with everything that we could possibly need to be safe. Some of us have just managed to throw together some sort of dinghy, and some of us have absolutely nothing at all. And as a result of that, some of us succumb to the factors that are completely out of our control. I'm incredibly determined to break that cycle. So what motivates me is helping others to recognise that as healthcare professionals, we have a responsibility and a duty to understand that we don't all have equal access. It's our role, no matter what role we do, to support everyone to access the care that's needed for them. I hope the webinar series is a tool to help me achieve this. So my one and only take-home message, and everybody will be giving you this important message throughout the series, is that health inequalities is everybody's role. And by just doing one thing differently and supporting each other, together we can make systematic changes to benefit everyone, not just a select few. And on that note, I am so thrilled and excited and incredibly honoured to introduce you to my colleagues who will be supporting me on this webinar journey. So we have James, Amy, Sally, Adele, Harriet and Sarah, who will be talking you through some of the amazing work that they've been involved with, and more importantly, how your role fits within that and what we can do together. So without further ado, James, I believe you are taking the floor.
Great, thank you, Kim. And first of all, thank you very much for kind of sharing your experiences as there. I think really important, but recognise personal sharing can be really difficult as well and challenging. So thank you so much for highlighting that, because I think it just kind of sets the tone and also in terms of the direction and keeps the focus, because focus is about the individual and how we can support the individuals through innovation, through whether it's through research, through innovations, whether it's through our services across the system there. So before I go on, my name is James Thomas. I'm the medical director for the West Yorkshire Integrated Care Board, and I'm also a GP of many decades. And I'm here to I've got a short time, and I'm not expecting anyone to kind of remember it all, but it's kind of just being able to kind of give a better understanding. And I've been asked to give a better understanding of the system that we work in across West Yorkshire, and not to memorise it, not to be able to kind of any quizzes at all there, but to understand that. So we just go on to the next slide, if that's okay. So as a system, you may hear the term integrated care systems. And essentially, those are partnerships between health and care organisations, and many of those across West Yorkshire, that come together to plan and deliver joined up services to improve the health of the people who live and also work within the West Yorkshire Health and Care Partnership. And we are one of 42 integrated care systems across England there. And our purpose is to enhance that productivity and value for money. It's essentially about also improving health outcomes of all people, using kind of make sure we've got good data and good insight into that. But importantly, that we are tackling those inequalities in experiences and outcomes and access to our services there. And also by doing this, we're also helping support the broader social and economic development across West Yorkshire. Next slide, please. Within that system, we have our four main priorities, and it's very similar in terms of it's how we use our collective resources wisely. So we've got one pot of funding across West Yorkshire through our health and care system there. So how do we really get the maximum benefit of it there? So we're kind of greater than the sum of our parts in terms of our outcomes there. One of our big objectives is about reducing health inequalities. If we don't focus on that, who else will? So it's really key that we have that focus there. It's also about managing unwarranted variation across our system in terms of how we look at West Yorkshire there. And it's about, and again, securing that wider benefits across health and care. West Yorkshire has 2.4 million people across it there, and across West Yorkshire you can look at kind of the governance arrangements there. We have a partnership board, we have the West Yorkshire Integrated Care Board, which I'm the medical director of there. We will also have a collaborative across West Yorkshire with our acute trusts, so that's the WYAT, West Yorkshire Association of Acute Trusts. We have our mental health and learning disabilities and autism collaborative. We have a community provider collaborative and a hospice collaborative there. That's across the whole of West Yorkshire. Our West Yorkshire is made up of 5 local places, and across those places there are individual arrangements, whether it's health and wellbeing boards, integrated care place committees, through our councils, our NHS trusts that work within those areas, our primary care and our Health Watch and voluntary sector as well. And then within those places, we have our neighbourhoods. West Yorkshire has 52 neighbourhoods that are made up of 52 primary care networks, in which across those networks, we're looking at primary care in terms of all general practice, dentistry, pharmacists, opticians, social care providers, as well as many others. Next slide, please. This slide, again, I'm sure will go out to you. I'm not going to go through it, but it just demonstrates the number of organisations we have across our health and care landscape, across our places and across West Yorkshire there. That includes kind of just under 300 general practices. That includes just over 500 community pharmacists, just under 300 dentists practices there, and I can go on and on. And especially via voluntary sector, there are kind of almost 12,000 voluntary sectors and social enterprise organisations across our system there, all of which are providing important health and care services for our people there. And that's not including our big organisations that I've previously mentioned and are demonstrating on this slide there. So go to the next slide. But the key thing is, great, we've got some organisations, we've got arrangements and governance arrangements around that there. But the key thing is about making decisions with our individuals. That's the most important thing, was we want as a system to make sure that people have the best start in life so that you can live as long and age well. And it's important that we build on lessons that we've learned from the COVID pandemic to make sure that we're kind of building this together in partnership to ensure we can kind of get the right outcomes that people want. So that starts with those individual conversations. So me as a GP sitting with a patient, having those conversations and making those decisions there. And that's where it really should be taking place across with individuals, if not across our neighbourhoods, so that we make sure people are getting the right care in our neighbourhoods there. But we also recognise that sometimes that's not possible. Sometimes decisions need to be made across our places there. So things like tackling health inequalities in their places may be something you do collectively across your place there. Also looking at other things like housing. It might be that we know the wider determinants have real impact for health and care. And again, there's those things that we might do across our places. And then across West Yorkshire, sometimes it's appropriate to make decisions across West Yorkshire as a whole there. And that might be working across our hospitals. So sometimes going to your local hospital might not be the right thing, because actually the specialists are in another part of our system there. So it's how our hospitals work together to make sure that the individual back in that community gets the right care as close as they can. That will get them the best outcome there. It's also working across West Yorkshire is about kind of sharing good practice where it's working well, and sometimes where it's not working well as well, so we don't make the same mistakes. But it's also about kind of if there's one thing that we're all seeing as the same is this main issue, is that we work together on that rather in 5 different ways. And sometimes there's some kind of wicked problems that actually collectively together will make a bigger impact on working together there. So working across West Yorkshire is the right kind of footprint to look at that there. But the heart of this is about the individual in terms of their care. Next slide. So very quickly, we've talked about the missions. It's important that we have values and behaviours that we adhere to enable that partnership working so that we can collaborate, make sure that we are ambitious so that decisions are motivated by kind of shared purposes, whether that's in our communities, across our places or across the system there. It's always making sure we've got that right data before we start taking action there, so that we can make sure we are critically thinking and making sure we're getting this right there. And it's important, as I said, it's about kind of sharing power, but retaining accountability where we need to, but making sure that we make decisions where we can as close to people as possible. Next slide. And why do we do this? As I said, we do this for the individuals that work and live across West Yorkshire. We have 10 big ambitions collectively as West Yorkshire that we've come together and decided these are the right things to be doing something about at the moment there. So those 10 big ambitions are in the slide there. It's about increasing the years of life that people are in good health in West Yorkshire. It's about increasing our early diagnosis rates for cancer. It's about reducing those suicide rates. It's about reducing antimicrobial resistance. It's about reducing stillbirth and neonatal deaths and brain injuries and maternal mortality there. Importantly, it's about reducing that gap in life expectancy between people with mental health conditions, learning disabilities and autism and the rest of the population there. And it's about addressing the health inequality gap for children living in households with lowest incomes there. Our leadership needs to be more diverse, so it reflects our population and reflects our population's needs there. And we also recognise our impact in terms of tackling climate change, whether that is as a system, as a big organisation, but also me as a GP, maybe prescribing inhalers and what that really means there. And in doing all of this, we're looking at kind of how we strengthen our local economy, because we know that wealth and health are so much linked there. I'm not going to go through the rest of the slide there, but it's kind of how we do that. But those are our 10 big ambitions as a West Yorkshire system there. And the final few slides really are just examples of actually where we've come together, both in our places and across West Yorkshire, and really had real impact by having campaigns, making people aware, bringing people together to really understand what people's needs are, so we can really address some of those issues and some of those problems. And I think over the next few weeks, when you go through these webinars, hopefully you'll see some of that coming out in terms of the focus that we've done in our places, in our organisations, to address some of those ambitions that I've highlighted there in a way that reflects our ambition as a system, and reflects our behaviours and our values, and focuses on the individuals where it's appropriate, but also across our places and across our system as well. And I think the last slide is another example there of some of our campaigns we've done there. So really, I'm aware of time. I'm aware that I've come probably to the end and even overrun there. Apologise for that. But it's just to give you some insight into some of what is West Yorkshire. What do we talk about when we talk about integrated care systems and there? How and why are we working together in terms of planning our services? And I hope that gives you a bit of insight into what we're doing as we go through these webinars. Thank you very much, Kim, and thank you all.
Thank you so much, James, and very appreciative. And it's a great snapshot of some of the stuff that's happening in West Yorkshire. And I would just say at this point, again, to reiterate, please do not worry about remembering everything that we give you today. I did forget to mention that there will be a resource document that will be circulating once the webinars have completed. So everything that we're talking about in these sessions, all the information, you will have everything in a useful pack for you to have and refer back to at a later date. So don't stress about retaining the information. Just sit back and enjoy the story that we've got to tell you. Thank you so much, James. And Amy, we will move on to the magical world of innovation.
Hi, so I'm going to be super quick to help us get on time. So my name's Amy Lochte. I'm the Innovation Hub Director for West Yorkshire, and I have the very big joy of sitting across two organisations in both the Health Innovation Network and the West Yorkshire Health and Care Partnership. So next slide, please, Kim. So if you talk about innovation, it's probably the most exciting thing with the least exciting definition attached to it, unfortunately. And that definition often makes innovation feel really inaccessible to people. So innovation, if you go by Cambridge Dictionary, is a process by which a domain, a product or a service is renewed and brought up to date by new processes, techniques, and I won't go on. And it's all about creating value, defining characteristics of innovation. Now, if you're a normal human being, that means absolutely nothing. That's a load of words on a piece of paper that doesn't really mean anything and you can't apply day to day. So when I was thinking about how do I explain this, if we can go to the next slide, I used my 4-year-old. So this is Rupert. Rupert is 4. He is a massive lover of Lego. Hopefully Kim will press. He's also a huge fan of Spidey and His Amazing Friends. Dinosaurs are his absolute #1 thing, and his favourite song currently, which I am extremely proud of as a parent, is Shake It Off by Taylor Swift. So as you can imagine, trying to explain my job to a 4-year-old probably isn't something that's very easy to do, and innovation in itself isn't very easy. He thinks that I work with robots and that computers do everything and that my boss is Iron Man, which, you know, I think our boss would probably like to think he's Iron Man, but I can guarantee you he's not. So I thought about how do I explain what innovation is, and that is thinking about something in a really cool new way that's never been done before. So how do you build a better Lego tower that is taller, that it's stronger, and that can go up against everything? How can you make a new game that's more fun to play or has better inclusivity of the people that you're working with, and how can you use your imagination to think about how to make things work better. Fundamentally, that is what innovation is. And every single person on this call will have at some point in their career, in their personal life, been innovative in how you do that, whether that is thinking of a new game to get your 4-year-old to bed, which is often my challenge, or if it's bringing in a new technology or AI into a healthcare service. All of them are the same. So next slide, please, Kim. But innovation, however, is one of the joys of being in the most grey area in health. So the reason I say that is because it blurs the lines across so many different disciplines. And I really try to not define innovation, because the minute you define it is the minute you silo yourself into a particular hole, and that's not where we sit. So for me, innovation has to work hand in hand with research, with improvement, within transformation. And if hopefully Kim clicks, my next Taylor Swift reference is here to say the middle bit is absolutely the sweet spot of where we all want to work and go with innovation. So next slide, please, Kim. So if you are thinking about innovation in a really linear pathway, this is what it looks like. This is our bread and butter of how we go from an idea all the way to spread and adoption of an innovation. What I can tell you is, by no means is innovation a linear process. We jump from all of these hexagons back to forth on a day-to-day basis. So coming up with an idea, and that can be something as simple as, if I move a chair in a waiting room, is it going to mean that patients are going to see information better? There's going to be better flow. You're going to be able to see if a patient's sicker sooner. That's just as innovative as building a large language model that helps to create an AI that looks at risk stratification, which are all words that, if you're not used to, again, just sound like words. We do that in collaboration with our research colleagues, with our transformation colleagues. So you have to take an idea, but then research actually, is this something that we need? And actually, do we have the culture in our systems to do this? If your culture's not there, you're missing half of your problem. Then you need to work out, does this actually fit an unmet need? Are we just making something for the sake of something? And that's part of what we do in health innovation, is that we turn around and go, actually, we don't need this. This is not what the system needs. Actually, here are the needs that we have. Go away and fix it for that problem that we've got. We then think about, how do we ensure that actually patients and public have been involved in this? And that is really important when we're thinking about our health inequalities. Sitting up in an ivory castle and building a solution to a problem that you don't understand means that this is going to fail. And one of the things that we have to do in terms of innovation is think about a pathway over a product. So putting a product into something is not going to fix the problem if it's going to make the pathway fall apart. So through that, you want to work with people. One of the big things that we do as an innovation hub is really challenge our innovators on, where are you working in reducing health inequalities? What are you doing to support that? And ultimately, if they can't show us that they have done successful patient and public involvement and have shown a decrease in health inequalities based off the use of their innovation, it doesn't get past us, and they have to go back to the drawing board and come back to us. As you can see, we go through the clinical trials, the real world evidence. That all sits in the lovely research part, which Sally will come on to. But again, like I say, research is that very grey area of that Taylor Swift sweet spot in the middle. Then you want to think about, how do we then put it into adoption and then scale that and make sure that actually we're seeing that evidence and we're constantly going back. So we constantly move across this kind of pathway in a non-linear way to ensure that innovation is right for our systems and right for our patients. Our biggest role, however, is whenever we're bringing an idea, we're thinking, what does this mean for the person that would have the least access to healthcare, and is it going to help them the most? Because that is where we're going to see the biggest impact. I have done this in a really short amount of time because I want Kim to keep on track. So I'm going to stop there. I will put my email address, however, in the chat. So if anyone does want a bigger conversation around this, please do get in touch. But I hope that that helps give a bit of an understanding around why innovation is so important and how everyone has a role with it in our system.
That's amazing, Amy. Thank you so much. And to condense what you just have in the time that you have is an achievement in itself and a skill that needs putting on your CV. Because if you can describe innovation in 7 minutes, then you've got something that you could sell there, Amy. Thank you so much. And as Amy alluded to, we've been talking about research a lot within that and how important it is. So I'll very gladly hand over the floor to Sally, who will talk to us everything about we need to know within that area. Thank you so much, Sally.
No problem, thank you. I am Sally Bridges. I manage something called the Applied Research Collaboration for Yorkshire and Humber. It's funded by NIHR, which is the National Institute for Health Research, and the ARC, as we call it, the Applied Research Collaboration in Yorkshire and Humber, is the research arm of West Yorkshire's ICS. Next slide, please. So this is the difference between an innovator and a researcher. I've chosen 3 definitions that we can look at, and we can compare them all and come up with something generalizable. So my first one is Claude AI telling us what is research when I asked him what the difference between research and innovation was. So there we've got research being a systematic investigation aimed at discovering new knowledge, facts or principles. Then I looked at the NIHR, the National Institute for Health Research, and they're acknowledging that it means different things to different people, which I think is really important to do. But essentially, it's finding out that new information, but this time focusing on things that lead to improvements or changes. And then the Department for Health and Social Care, they bring in extra elements, I suppose. So they're talking about this new knowledge, but making that new knowledge is derived from clearly defined questions in a systematic manner using rigorous methods. And the whole reason that you're trying to do it in that way is so that what you find is generalizable. So you can do it in one space, but actually we're confident that the results and the evidence that is generated is applied, you can apply to other spaces. So now we've got a definition. I just wanted to talk a little bit about how research is categorized, and there's loads of different ways to do this, but here's just one way. So this is the different research infrastructures that are funded by the National Institute for Health Research in the UK, and this is organised according to stage, if you like, or the other way to think about it is the sort of proximity to when people are actually going to start realizing the benefits of whatever it is that you've got. So on the left hand side, you've got the early stage, into the clinical stage in the middle, and then adoption is where you start to see it in policy and practice. So if we take drug treatments, for example, it'll be a pharma company making that early scientific discovery, and then that might get picked up by our biomedical research centres or our clinical research facilities to develop that new treatment. That might then develop into something promising that goes into, say, the clinical research network as a trial, and we might start seeing that people experiencing that treatment. And yes, it's effective, great, and it's safe, brilliant, let's roll it out. But actually, there's still research to be done there to think about how is that being rolled out? Are there barriers to the uptake of that treatment? Are there barriers to the way that treatment is prescribed by professionals? So there's research all the way along that pathway, and it never really ends. There's loads of other ways to categorize it, as I've said before. So that might be by method. So you hear about lots of different research methods, and I'm not going to go into that on today's webinar. But people define it by either qualitative methods, which is more about understanding what people think and feel about something. That's often looking at different documents you can categorize by, or conversations with people. People categorize that compare that against quantitative research, so surveys, numbers, all of that number crunching stuff. In reality, a lot of research that we do tends to be what we call mixed methods, so a mix of the both of them. So you get to understand quantities, measures, but also the why and how things work and for whom. So I just wanted to focus on this slide as well, because I think it's important, and as I am a researcher and I work in the research space, but I think it's really important when we're thinking about the health and care space that we appreciate that research is just one type of evidence that is important and useful in that space. So here is a slide that is trying to summarize different evidence types. So you've got research there on the top. Things like evaluation, improvement and development information is there. Then you've got things like audit, as well as health surveillance and population health management. And there's different definitions on there, which I'll let you look at your leisure when the resource pack comes out. And whilst this evidence can be generated in different ways and used in different ways, the thing that links it all together is this idea of it being collected in this systematic manner. And it can, and all of these different information types can come from different levels. So the lines running through those circles there are trying to demonstrate this idea that these evidence, all these different methods, might come from the public or patients, it might come from staff, or it might come from organisations and systems. So we need to be making the use of all of the available evidence when we're trying to make decisions on things. And it's really important that we're appraising the evidence systematically as well. So taking that sort of research mindset, not just in the production of information, but also how we're using that information. And just, oh yeah, thank you. I was thinking about how to talk about research given today's focus in the webinar, and I thought I'd illustrate it briefly, this idea of how research and innovation can link together with an example from our region. So TytoCare is a remote monitoring device. It allows clinical grade measurements and assessments that can be transmitted securely to clinicians. So this device is an innovation. I think we can all agree with that. It's a new way of doing something. That's my definition of innovation. So it's just a new way of doing something. So clearly lots of research will have gone into developing that innovation. You know, what camera to use, you know, is this grade equivalent to what you would see in a clinical space, you know, all of that kind of stuff. And then once that is ready, then we need to be supporting it to be rolled out. So if we just click again, we can see here that TytoCare was supported by our colleagues in Health Innovation Yorkshire and Humber to be deployed across our region. And that was about looking at supporting organisations to be able to use it and to support that uptake. But it doesn't stop there. So we've got this innovation that was developed with lots of research, no doubt, in the background. Then you've got it ready to go and out it goes to the system. But it doesn't stop there, and it shouldn't stop there. And if we can just click again, we can just see a little excerpt from an evaluation that we did looking at the medical device across our region. And it's not particularly about the findings of this study. This is just a case study to demonstrate. It's really more about this idea that once we have an innovation, we really do need to understand how it's used. You know, is it effective? Do staff and patients like it? Does everyone have equal access to it and equal outcomes from it? Because, you know, we've heard today how incredibly important health inequalities are. And research can really help us to understand more about those and ensure that the innovations and improvements that we're making are actually actively reducing health inequalities rather than accidentally exacerbating them, which can often happen just because it hasn't been considered. And something we do know about is this idea of intersectional disadvantage. So it's not like people who are disadvantaged by income are here, and people who are disadvantaged in terms of being a minoritized ethnic group are here, and people who are disadvantaged by gender are here. That's not how it works. In fact, it tends to be intersectional, and you get these sort of compounded inequalities, I suppose. And so it might be that there's just one tiny thing in this innovation that is bad for one group, and it's one in this and one in this. But actually, when you put all of that together, it can be very damaging. So we do need to think about it from that perspective. Oh, I'm nearly a minute over, so I'm going to rush on my last slide. So if we can go on to that, I just wanted to finish on this one, which is just a little bit of a slide from the research ambitions of our West Yorkshire Health and Care Partnership. And I just wanted to draw your attention to that first one. So the first ambition in our strategy is to make research everyone's business. And that is absolutely top priority for us, because research isn't just for researchers. It's not about doing the research. You've got the doing the research, you've got the posing research questions, being curious, asking questions, but also thinking about when you're doing things and making changes, what's the evidence that's out there for that? How can I bring that evidence from research and other evidence types into that decision making so that I'm involved in that research process and applying those research findings into practice? And I will hand it over to somebody else.
Thank you so much, Sally. Again, the amount you've covered in the amount of time I've allocated. And I'm just going to say I'm so impressed. I did have a very slight, gentle word with everybody to say we've got loads to cover, so if you can keep to your time, that would be great. And so far, you guys have 100% delivered, so I'm incredibly impressed. Thank you so much. And thank you so much for opening our eyes to research. Massively important, and sort of all cards on the table, a world that I'm not 100% aware of, and that has absolutely made it a lot, much clearer for me, Sally. So thank you so much for sharing it with us and just giving us that taster. So we are now moving on to health inequalities. Again, an absolutely vast subject topic. So Adele, the amazing job of trying to condense this in the time is all yours. The floor is yours.
Thanks, Kim. So hi everyone, I'm Adele Bunch. I'm Head of Portfolio at Health Innovation Yorkshire and Humber, and I lead on all things health inequalities, mental health and patient and public involvement. And when Kim says you need to tell them about health inequalities in 7 minutes, I thought, how am I going to do this? But I'm going to try. So next slide, please, Kim. So what are, oh, that's in the wrong order. Did that go on too there, Kim?
Yeah, that's the next one I add on.
Okay, no problem.
If you've got it up, I can stop sharing and put yours on if that's easier.
No, it's fine. I think it's just these two have flipped. It's fine.
Okay, no problem.
It's fine. So I'll just start by saying that the case for change for transforming health inequalities is really big. This has been around for decades. It's not new. So Michael Marmot, Lord Darcy, Bola Owolabi, for a long time they have been talking to us about the case for change, and there's lots of literature and lots of narrative, so please familiarise yourself with that. In essence, they've existed since the 1800s, so for centuries and decades. Next slide, please. So what are health inequalities? So health inequalities are the avoidable, unfair and systematic differences in health between different groups of people in our population. And these differences impact on things like how long people are likely to live, the health conditions that they face, and the care that's available to them. And when we think about health inequalities today, I want you to think about people in our populations, and think about them with compassion. Think about everyone in your community and how they use your services, access your services, and that might be difficult to access. And think about the experience of them and how that might determine the outcomes of their care. And the second point I want to make is that health inequalities is not wholly a direct result of the NHS. There are many factors that make health inequalities, and the NHS cannot fix this issue alone. And I'm going to talk about some of the wider determinants of health and the reasons why. Next slide, please, Kim. So it is a stark reality. And first of all, I'm going to talk about some statistics that affect people across the country. So if you live in Blackpool, you will typically live 10 years less than people in the southeast. If you've got a learning disability, you're unlikely to see your 65th birthday. We know that COVID brought many health inequalities, with ethnic minority communities and disabled people had a risk of dying 3 times as much as, and sorry, I've completely ruined that, forget that one. Primary school children, if they are obese, they typically live in high areas of deprivation. And we know that accident and emergency sees high intensity use from people living in deprivation, and West Yorkshire's done some studies on that. Last week I attended a conference with Lord Darcy, Bola Owolabi and Sir Michael Marmot, and unfortunately this narrative is not changing. This narrative has existed for a long time, and it was quite upsetting really to sit there and hear it, cemented again. But what I will say is that Bola touched on the amazing work that is happening across the country and in regions. And now if we look at physical health in Yorkshire, you can see that depending on a postcode, if you look at cancer, for example, and the physical health of people with cancer in Bradford, that's sitting currently at 2.3% better than the England average. But in Calderdale, it's 13% worse. So you can have a region, but within that region, there can be quite stark differences. Next slide, please, Kim. Yes, it is surprising. Next slide, please. Will it move on?
Sorry, bear with me. It's taking me to the links rather than the next
Don't
one.
worry.
Let me see if I can do it in a different way. There we go.
Thank you. So what causes health inequalities? Well, almost every aspect of someone's life impacts health and ultimately how long people live. And these factors are referred to as the wider determinants of health. And health inequalities, it starts in the womb. So before birth, the likelihood of suffering inequality relies on the health and well-being of the mother and the environment in which that child grows up in. So as a child develops, their life journey, their education, or their lack of it for multiple reasons, shapes their life opportunities and their behaviours. And geography is a really important consideration. So where somebody lives and their home can really determine their quality of life and how easy, for example, it is to access services. So if they live rurally, they might not be able to access transport networks as easily. And people that live in really cold, damp homes can experience, for example, respiratory conditions. And then if you look at certain characteristics protected in law, such as sex, ethnicity, disability, these can lead to discrimination. And poor understanding of somebody's condition through no fault of their own, due to language barriers or a learning disability, for example, can often result in the case of a learning disability patients, their symptoms being overlooked and often poor consequences. And if you look at the health inclusion groups at the bottom of this presentation, so people that are homeless or people that are in our asylum system, they can really struggle to access our systems due to stigma, digital exclusion, or language barriers. And people in these groups are more likely to live in poverty and have poor housing, experience discrimination and violence, and have ultimately less access to healthcare services. And it's important to consider that all of these factors, the wider determinants, are often linked, so people can find themselves in a really vicious cycle. Next slide, please, Kim. So why these factors matter. For us to truly stamp out health inequalities, we really have to understand why people struggle. So if you think about our average reading age in the UK, it's 9. So 43% of adults don't understand written health information. And then if you think about our ethnic communities or our asylum seekers who don't speak English, that makes it even more difficult for them. The quality and experience of our services is a consideration. So we know, and the Race and Health Observatory are doing a lot of work in this space, Black people are 4 times more likely to be sectioned than white people presenting with the very same symptoms because they are simply misunderstood or not listened to. And living conditions, as I've said, if you live in a damp, cold home, this can exacerbate not only respiratory, but cardiovascular disease, poor mental health, dementia, hypothermia, and this affects childhood development. So what have we got nationally to tackle some of this? So Bola Owolabi, she heads up the NHS England Health Inequalities team. And a couple of years ago now, the Core 20+5 policy was developed. So this aims at targeting the Core 20, the lowest IMD populations in our populations, looking at the key clinical areas where we know stark inequalities exist, focusing on those inclusion groups that I mentioned earlier, who we know typically don't access services, with smoking cessation sitting throughout. And I actually think obesity should also be added to Core 20+5, but that's something that we're exploring with NHS England. And then moving on, a little while after the adult version of Core 20+5 came out, we then had the children, the one for children. So that concentrates on asthma, diabetes, epilepsy, oral health, and mental health. And again, it's focusing on those Core 20 populations and those plus groups that we know are underserved. So what are we in Health Innovation Yorkshire and Humber doing to tackle health inequalities? Well, we have a fantastic programme called InHIP. I won't say much about it because I think Harriet's going to describe that. But ultimately, that's working with that Core 20+5 framework to tackle inequalities amongst those groups. We run a really good health literacy community of practice with North East and North Cumbria Health Innovation Network. That's made up of about 350 people with an interest in health literacy. We bring along innovators that help to tackle the the challenge. So if you're interested in, if you're doing things in the health literacy space around developing, you know, whether it be avatars or different labels or different mechanisms for people to understand their condition, please do let us know. We run something called the MedTech funding mandate. So in that policy at the moment, we are, and it's Harriet, she's doing a fantastic job. We are transforming sickle cell services throughout widespread adoption of Spectra Optia, which is automated red blood cell exchange. We've got some other work in ENT and urology services, a big agenda around CVD and meds optimization via the rollout of the CVD program and the drug inclisiran. And really importantly, when I talk about listening to patients and the value of patients, we've got a new patient insight framework designed to help you do just that. It's published on our website. That ensures that lived experience of patients factors into spread and adoption planning, so that when innovation is rolled out, that patient voice is factored in. And then your role in supporting this important agenda. So please understand health inequalities. Think of everybody as 1-year-old infants and 100-year-old adults. You know, treat people with compassion and consider it as a golden thread in your activity. Work inclusively with patients and the public. You cannot underestimate the knowledge and the lived experience that they can bring to transform your services. Listen with fascination. And ensure that health inequalities are the top priority within all levels of your organisation. We know that national funding comes down from NHS England, about 4% of the NHS budget, but we know some of it falls into black hole deficit. So work with your board, work with your organisation, fight the cause and try and get some of that money landed where it needs to at place. These slides will be shared. There's some links there to some recent publications and things that I've mentioned, and the new framework. And please do reach out to me. You know, Harriet and I and my team, we really want to get some good health inequalities projects off the ground, and we can help you navigate some of this landscape. So do reach out. Thanks.
Amazing, Adele. Thank you so much. And again, just to reiterate the sort of mountain task that you've had in trying to condense this in the time that you have. It has meant that we're running ever so slightly over schedule. So just to give you a heads up, it's a cumulative effect, Adele. We've all overrun, as we knew would probably happen. So it's just to make you aware and just to try and bring it as close to half as we possibly can. Aware that obviously people have lots of other commitments other than this. So stay on for as long as you can. But thank you very much, everybody. We will now be moving on to Harriet, and obviously Adele has mentioned some of the stuff, but Harriet, the floor is yours.
Thanks, Kim. And everybody knows that I can talk on health inequalities for probably about 6 hours. So, you know, putting me last was not a good idea. Also, it's just dawned on me that I'm following 3 experts in talking and trying to pull together innovation, research and inequalities. So I've realised what a difficult position I'm in.
It's very difficult, Harriet. We do have Sarah with us today, who's also going to help you pull that together too. So you've got the floor with Sarah after yours. So you're not quite last, but
double trouble on Sarah. So my name's Harriet Smith. I'm the workstream lead for the Accelerated Access Collaborative, but also lead on some of the INHIP regional projects that we run as well. And you've heard about innovation, you've heard about research, you've heard about inequalities, and this part of the seminar really is to just pull it all together. And how do we do that as a health innovation network? And when I was thinking about this, I just think about these projects in terms of one huge jigsaw, but different people hold pieces, and often those people are even from different organisations. And if one piece is missing, or if one piece is the wrong shape, then it can really tip these projects, you know, and throw us off course. They can have a major impact. And I think the other thing to be careful of when we're running these sort of projects is not to make assumptions. So, for example, we're rolling out a point of care cholesterol test with the Gypsy and Traveller populations, but people are actually respectfully declining our offer. Or we're putting on a huge BP health check event with free lunches, but it's on the first day of school and nobody can attend. Or we're putting on an England boxing session to engage a specific population group, in our case, the Gypsy and Traveller population, but we put it on in the wrong postcode and nobody actually wants to go. Or we want to track our impacts through to see if we've actually helped people, but those people aren't registered with a GP, so we can't see the end result. And I could go on, but I won't. And the reason is because these projects are all absolutely great and we need to do them. And we need to constantly try with new innovative ways. And I think lots of people think about innovation as that shiny bit of tech, but actually pathway change is just as important. So how do we do things right? How do we learn and how do we improve? Next slide, please. Jigsaw piece number one is funding. I'll skip through this quite quickly because Adele mentioned it, but within Yorkshire and Humber, we managed to get £300,000, so £100,000 per ICS to run an INHIP project. So we specifically worked with local places to define a population group who needed our help and support, who were underserved, and then we needed to link it with a NICE approved technology and see whether we could get any improvement by matching these people and these technologies together. In Yorkshire, we ran 3 projects. 2 are from CVD, cardiovascular disease, and 1 was on asthma. Next slide, please. Jigsaw pieces number 2 and 3, the community and their need. And I'd quickly like to run through one of West Yorkshire's inequalities project, which was run by Pei Teng, a pharmacist in Leeds, and it was called Healthier Cholesterol for Your Community. And she targeted population groups from Beeston, Middleton and Hunslet PCNs, as well as the Gypsy and Traveller communities. And why did we pick them? And Adele has already alluded to this as well. Leeds Observatory Intelligence reported that African, Pakistani and Indian communities were the top 3 ethnic minorities groups with a high percentage of CVD. And the Gypsy and Traveller communities were approximately dying at 50 years of age, as opposed to the Leeds average of 78. So there was a reason why we picked them. A large part of the Gypsy and Traveller populations as well were not registered with GPs. Next slide, please. Who holds the pieces? This comes back to James's slides at the very beginning. You can't do this in isolation. This is how complex it gets. So one small project had 7 key stakeholders here. And, you know, no inequalities presentation would be complete without Helen Keller's. Alone, we can do so little. Together, we can do so much. This really epitomises that, I think. Next slide, please. Jigsaw piece number 4 is innovation. So the innovation we chose for the INHIP project in West Yorkshire was POCDoc, a healthy heart check. And it's done at the point of care, which means that the clinician is with the patient and the patient will get their test result within 7 minutes. And the whole research element to this was, could we marry up this technology with the selected communities? Could we take this check into community settings? Could we involve pharmacists and wellbeing coaches as well? And could we test and educate people attending those sessions? Basically, could we be more accessible, approachable? Could we work effectively with other stakeholders? And I suppose more importantly, could we make a difference? Next slide, please. I nearly said next jigsaw puzzle then. Jigsaw piece number 5, research. What did we find out? We've had 203 people engaged. They all got health advice. 35% were not registered with a GP, and 3% were started on treatment, but a quarter of the people that were tested were referred back to the GP or the community pharmacy. And these were people who arguably would never have sought care from a GP beforehand. Perhaps the biggest success, in my opinion, was the joint working and the putting together of the puzzle, because effectively working with Leedsgate and the council, and by taking it really slowly to build up the trust and acceptance at the beginning of the project, which I must admit made Adele and I a bit grey because we were thinking this is taking too much time. But it paid off, because by the end of the project, we were being invited into community leaders' homes on the Traveller site, with people coming to that venue to ask for advice. And one chap who turned up, he was given a whole heap of medications 10 years ago, had given them up. He didn't have a GP. He couldn't really access his prescriptions. He didn't understand what those medicines were for anyway. So by being there in that community, the healthcare professional could sort of work with him and probably and hopefully put some solutions in place. And I also mentioned the work we did with England Boxing at the beginning. We didn't attract any members of the Gypsy and Traveller community because we were in the wrong postcode. But what we did do was we attracted a wonderful group of South Asian ladies from Hamara who absolutely loved the boxing and had an absolutely wonderful time. So it doesn't work out always what you think is going to happen, but that really doesn't matter. This staff feedback, you have to go back, Kim. I'm sort of ahead of myself. This feedback really epitomises this. This is a member of Leeds Gate who are part of Leeds Council. Gaining access to our community can be very challenging for outside organisations and agencies. By partnering with us, it enabled the InHIP project to gain access to our community as vouched for partners. Leeds Gate would not have had the expertise to run a much needed InHIP project that would benefit our community's health and well-being. So the final slide and the final piece of the jigsaw is about sustainability. How can we refine and perfect this approach? How can we demonstrate to the senior leadership teams within the ICBs that they are both cost effective and sustainable? Because pilot fatigue is real and short-term sticking plasters are starting to cause a little bit of mistrust in patients and staff actually. And can we use the evidence and the research to pull out real world evidence reports so to make sure that the senior leadership teams have the information that they need to make informed decisions that need to affect real and meaningful change. Thank you.
Thank you very much, Harriet, and again for squeezing it in that time. To say at this point, for anybody who is needing to dash off, very conscious of the time, this is being recorded and will be shared with you after. For anybody that is able to stay with us, we have got the amazing Sarah, who is just going to highlight some of the amazing work that she's done that sort of encompasses everything that we've been talking about today. So it's really, really helpful and useful if you can stick around. No pressure. I appreciate the time constraints, but Sarah, the floor is all yours. Thank you so much.
Thank you. I will try and whiz past. I do speak quite quickly. And just to echo Harriet's point about following the experts, I think that actually fits quite well within what I'm going to talk about, because I am not an expert in what I do. I started this project with a couple of others alongside my previous job role, and I just think that kind of helps to just cement the point that this can be done. You don't have to be an expert in what you're doing. You just have to have an idea and the passion just to kind of follow that through. So next slide, please. Yeah, so as I said, I'm Sarah Gapper. I work for a supported living charity called Choice Support, and we provide support and living services to people with learning disabilities, autism, and some mental health. I'm based in Wakefield, but we do move around. We are based up and down the country. And just around COVID times, we set up a project called the VIP Red Bag Scheme, which is a hospital bag that we've developed for people with learning disabilities and autism to take into hospital for any planned appointments, emergency admissions, any reason that they need to go in. And the VIP logo should be highlighting to the hospital staff that the patient has got additional needs and will need some reasonable adjustments while they're in hospital. What we encourage people to take in their bag with them is some personal belongings. We do put a list in there, so some suggested items, but most importantly, the hospital passport, which then the hospital staff should be able to easily find, read, and pay attention to the reasonable adjustments that are in there, with the idea of reducing the health inequalities for those people. As we know, we've talked about a lot on just this session, the health inequalities that people with learning disabilities do face. Next slide, please. So how did we start it? So yes, obviously the idea has to come first. You need to have an idea, and it doesn't, as again on one of the other slides, it can be something really, really small, or it can be something really big. If it just changes something for the positive for one person, then you're already doing a great job. The idea obviously is to roll it out to more people, but just start with that one person is absolutely brilliant. Next, your passion. You need to have that, and that will get you so many places. I've done presentations up and down. One thing I always get told is that people can see the passion that I have for this, as did some of my colleagues and the people who've come on board with me since then as well. Also get to some research done. So we actually did a bit of research, and we based this on the elderly red care bags that were released down in Sutton for people in elderly care homes. But we thought, how can we tailor this to the people that we support? How can we make this a little bit different? And we managed to get secure funding to get this out on an individual basis for people we support. Whereas with the Red Bag scheme for the elderly care peoples, that was done on a shared basis. I think the ratio was 1 bag per 10 beds, which we didn't think would work for people with learning disabilities, if they were in a shared home. People like to have their own things, their own belongings, especially some people with autism. That's their bag and it's not going to be shared with anybody else. Then we've sought help from like-minded people. Find your tribe. There are lots of people out there, and you join networks, join webinars, join conferences, webinars like this as well, and you will certainly find more people who have the same ideas and the same passion of changing things for people with health inequalities. And then on the bottom, social media is your friend. Some people shy away from it. And obviously there's some issues with Twitter and X that people have kind of gone, but use Facebook, use Instagram, use that. People will find you and you will be able to find people on there as well. And again, spread your word that way. So yes, how did we do this? As it says there, all good things start with cake, and it really does. So we didn't have any money. We didn't have any pots of money. We didn't know where to look for these pots of money. So we baked some buns and we sold them, and we raised 300 quid. And that was our first little pot of money just to do some prototypes. And then what we did was took the bag. The original bag was a different one when we took that on a tour of the services. So the people we support were involved in heavily helping us decide on the bag. The first one had a bit of black on it. So the people who have lived experience will be brutally honest in their feedback, which is what you want. And they said, that's not a red bag. That's a black and red bag. So we had to go back to the drawing board, back to Amazon and research and Google and everything else. And we actually came across this in a school supply shop. So again, we bought one of those, took that on a tour, and we got some much more positive feedback with the logo on there. Then, as like I said, you get talking to people and you find out about things. So we found out about MenCap's Treat Me Well campaign, and we put in a proposal to them, and we were awarded £1,300. So that was able to get us some more bags out to people. Again, talking to more people, someone told us about the Morrison's Community Fund. We applied for that and we were awarded £5,000. And again, talking, things started to snowball, and we got into conversations with what was Wakefield CCG. It's now West Yorkshire ICB now, and NHS England, and they awarded us £20,000 from each side, and that gave us a massive boost for the Wakefield area to manage to secure enough funding to roll this out to everybody who was on the learning disability register to have access to be able to have a bag, because we were giving the bags out for free. So as you can see there, that was 2,400 bags. Not everybody wanted a bag. Some people felt it was too much of a label, even though we do want it to kind of shout out loud and proud in the A&E department. So we also looked at lanyards and wristbands as a bit more of a discreet option for people. And then some of that funding actually went to, like I said, we were homes managers. I was doing this as a kind of a side as my homes manager job. So that managed to kind of pay for some admin time for us to kind of separate out from our usual day-to-day roles. And now I do this on a kind of a part-time basis along with some of the health organisation things. Next slide, please. So yeah, so what have we done so far? Like I said, it's snowballed from raising 300 quid with some buns to now we've given out over 16,000 bags to people. We've given training to the emergency department staff. It's now built into some of the training that the health educator in the Wakefield area delivers. We've done one-stop shops with the care coordinators around Wakefield. We've been to carers events. We've promoted annual health checks. We've done easy read guides, and we've even managed to create a small paid role for somebody with lived experience to come with me on events to help give the bags out, because that experience, I can talk about people's experiences, but they're not mine. So to come from the people who are actually living through these experiences is a lot, it's a lot more powerful. So what else have we got? So Bradford have launched the scheme as well. I had a conversation with Wigan, Warrington and Lee NHS, so they've done something slightly different and opened it up to people with learning disabilities. But again, it's just using that research, and it's just seeing what else is out there and developing it for your own needs. We're hoping to roll it out through the whole of choice support, and then the hope is to roll it out across the West Yorkshire area and even the country. That's our biggest dream. But not just to share, not just to kind of, we don't mind people using our ideas and what have you, but just to get that continuity of care and learning for people across. When they move around hospitals and health settings, you need to have that continuity of care. Next slide. So yes, we've also been added to Wakefield's health strategy. We've been recognised under last year's local leader report, and hopefully we'll be in there again this time. And we've been linking in with the NHS England National Peer Leader Network, as well as being invited to wonderful webinars like this to be guest speakers, which has been brilliant. One of the hardest parts of the project is getting feedback from people. We do put in feedback forms within the bags, but we've only had a handful of those back. The best kind of feedback is word of mouth that we have. It's always, oh yeah, somebody's told me this or somebody's told me that. So But just to focus on, yes, you will get some negative feedback. It's mainly been about the awareness of hospital staff recognising the bag. But do something about that and change that. But just make sure that you enjoy the good feedback. It is easy to get bogged down with the negativities in working in a project. So just, you know, keep those in your focus, but concentrate and celebrate the good wins that you get. Next slide, please. And just, yeah, my final take-home message is don't lose your passion. It is infectious to people. You know, that will get you a lot. And it is hard not to lose that passion sometimes. Like you said, you know, if you can't get funding for things or things aren't going quite right, it is hard to not to lose that passion, but don't. It will get you a long way. You are not alone. There are a lot of people in the same situation as you all are here today, looking at reducing health inequalities for people. And then the massive one at the bottom, there is always a little pot of gold somewhere, whether that is raising money with buns or, as Adele said, there's, you know, you can find something. There is a little pot somewhere that somebody might be able to, you know, siphon off for you, especially when you have the passion. People will help. There you go. 8 minutes, I think.
Absolutely amazing, Sarah. Thank you so much. And I'm so in awe of the work that you've done and how much you've grown it. And for me, it really does encompass sort of the, you know, the exact message that we're trying to portray here, in that, you know, you saw someone where you could help and support, and you've taken that forward. And it started with a very sort of modest, small bake sale, and grown so much, and the amount of people that you would have helped. So thank you so much for sharing that with us, and I hope that's been useful people on the call in terms of, you know, whether you guys are having ideas or thoughts, and you might not even be as developed as having an idea, you might just be able to see a gap and what to do with that. So the wonderful people that have joined me today on the call are very happy for you to reach out and talk to them, and we will support in any way that we can. This is one of 4 series, so we've got another 3 to go. The last webinar series is all about sort of fostering that organic and natural conversations between us all, and what we could do individually to take forward. Just as a lasting point, we for feedback on the webinar series, each one will be followed by a QR code, which Mal will also put the link in. I know some people have been having some difficulties in accessing, so we can share them separately. Again, it's not meant to be onerous feedback. It's literally for us to be able to measure that we've had some sort of impact and how we can improve, because things like this really rely on your feedback and input, and it's you guys on the ground facing these things every single day that help us inform these sessions. So if you have the time, if you wouldn't mind please leaving your feedback, that would be amazing. I hope that's given you a taster for what's to come and for the things that we're going to cover. There's so much to retain, but I hope it's been useful, and I hope it's ignited some fires in your belly to try and move this agenda forward and really make an impact within health inequalities and innovation. So I will leave it there. 12 minutes overrun. I promise it won't be this much going forward. Thank you all so much for your time. It really wouldn't be anything without all of the speakers and all of the guests that have come as well. So thank you so much. Have a wonderful afternoon, everybody, and she'll see you next Thursday for the next session. Thank you ever so much, everybody. Take care.